Welcome to the Office Hours Quality Payment Program, QPP, conference call. My name is Christine, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Elena Smith. You may begin.
Hello, everyone. This is Elena Smith. I'm a quality consultant with Lake Superior Quality Innovation Network serving Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this session of QPP Office Hours. Today's call will be operator assisted. By default, everyone's phones are currently muted to avoid background noise. Since this is an open office hours call, there will be opportunities to ask questions over the phone, at which time our operator, Christine, will provide instructions. We will also be closely monitoring the chat box and encourage you to post questions or comments throughout. Hi, Christine. I'm not able to forward the slides on.
There should be a toolbar on the left-hand side with arrow buttons that you can click with your mouse. Do you see that?
I am not seeing that. I'm only seeing like a plus and minus.
Right above that where it says 01:, there's little arrow triangles above and below.
Okay, thank you. So please note that the information provided during this session is based on the latest information made available by the Centers for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for interpretation and update. At the end of the office hours, you'll have the opportunity to complete a brief evaluation. We would appreciate your feedback about this event and suggestions for future educational opportunities. We'd also like to remind those of you that receive direct technical assistance related to QPP to please take time to complete the evaluation sent at the conclusion of each technical assistance encounter. Your feedback is valuable and allows us to gauge how we are doing in regards to meeting your information needs in a timely and courteous manner. Today we're going to discuss the 2018 QPP reporting. I would also like to mention that during the office hours call, we typically can address a broad range of questions which are based on the equally broad range of QPP MIPS knowledge level of our call participants. Some questions we will be able to answer quickly. Others may require some additional time to research due to the complexity of the question, while others will be scenarios specific to your organization. Our team is implementing a new process to capture all of the Q&A presented during these calls. Questions that our team deems broad and applicable to all in our audience will be emailed to participants within 2 weeks of this event. Those that are scenario specific, our team will address directly with the attendee via email and by phone. Finally, questions that require more research or those that appear frequently will be addressed at the next office hours. So the first thing I'm going to discuss are some important dates that have to do with reporting. So on January 2nd, 2019 at 10 a.m. Eastern Time, the Merit-Based Incentive Payment System data submission period for 2018 begins. On January 22nd, 2019, the MIPS data submission period for the CMS web interface begins. On March 2nd, 2019, the 2018 MIPS claims data submission closes, so if you're choosing that route, make sure you have your claims prepared. And then on March 22nd, 2019, CMS web interface data submission closes. And finally, April 2nd, 2019 is when MIPS data submission period for 2018 closes. So some extra dates to mention are that on July 1st, 2019, your performance feedback will be available. And then on January 2nd, 2020, the performance year 2018 payment adjustments will be put into place. So some reporting options you can choose from include individual, group/virtual group, and in this case, virtual group registration is now closed. CMS web interface, which registration for that option is also closed, and then finally, alternative payment model. Clinicians that are using claims-based submission for quality measures must report individually, and then clinicians that are part of a group may submit both with their group and individually, and the highest score they receive will be used for payment adjustment. So one of the important parts to reporting is that EIDM account set up. So you will use your Enterprise Identity Data Management, EIDM, to log into the QPP website to begin reporting. There's a detailed user guide for EIDM setup, which can be found in the QPP resource library or at the following URL, and you can find that URL in the chat. Of note, you may already have an EIDM account if you reported for MIPS last year or if you previously attested to Physician Quality Reporting System for year 2016. They require you to change your password quite often, so you may need to contact the Quality Payment Program to get access to your EIDM account. We will place both their phone number and email address in the chat, but it can also be found in the EIDM setup guide. After you complete all registration steps, it can take 72 hours up to 1 week to be confirmed. If you don't receive a confirmation email after 1 week, you should call 866-288-8912, which will also be placed in the chat for your reference. Again, all of these numbers and email addresses are located in the EIDM setup guide. This EIDM account setup is something you can make sure is ready to go now, so you can log in on January 2nd to start the reporting process. And again, you can find the user guide using the link shown, or it is on the front page of the qpp.cms.gov website or in the resource library. The other thing that you'll need when you're setting up this EIDM account is that you'll have to make provider approval rules. So if you're reporting as a group, you will need to designate someone as a security official, and if you're reporting as an individual, someone will need to be designated as the individual practitioner. These roles make it possible for those designated to submit data on behalf of the clinician or group. In the next slide, we will show you what information you will need to designate those roles. So if you are submitting for a security official role, you'll need the group's Medicare billing taxpayer identification number, or TIN, legal business name, rendering national provider identifications, or NPI, or 2 different eligible clinicians who bill under the same TIN and their corresponding individual provider transaction access numbers, or PTNs. Organization's address, city, state, zip code, and phone number. If you're going to be using an individual practitioner role, you'll need clinician's name and legal business name, clinician's Medicare billing TIN, clinician's rendering NPI and corresponding PTAN, and the address, city, state, zip code, and phone number. On January 2nd at 10 a.m. Eastern Time, after logging in using EIDM, you will be able to start submitting data. There is no submit button and the page saves automatically, and you will be able to update your information until the close of submission on April 2nd, 2019. CMS does suggest reporting early and putting your data in as soon as you're able, but it is open until April 2nd, 2019. Next, I'm going to give some audit readiness tips. My colleague Reed did a webinar on this topic, which goes much more in depth and can be found on the LSQIN's YouTube page, along with many of our past QPP office hours. So please feel free to check that out. I wanted to provide you with some audit readiness tips right now, and I believe we're going to be putting that link into the chat as well. So one way to help avoid an audit is to ensure your security risk assessment, or SRA, is fully complete. If you were to ever get audited, it would be very helpful to have an attestation file that is organized well. So these are some suggestions that we have for you to create that attestation file. So you'll want to organize the file by PIN, then by NPI, then by each MIPS category. All screenshots should include the vendor logo along with the date and time. the date shown needs to be during the corresponding reporting period. You should retain any data your electronic health record or EHR produces that summarizes MIPS reporting information. Retaining this data digitally will make it easier to submit the data if audited. If selected for data validation or audit, you will have 45 calendar days to complete data sharing unless otherwise discussed and agreed upon with CMS. Of note, CMS requires a 6-year retention period for MIPS, and the Federal False Claims Act encourages retaining data for up to 10 years. So if you have it organized nicely, it will be easy to find. And lastly, I'm just going to give a couple 2019 MIPS reminders. So in 2019, you will need 2015 edition Certified Electronic Health Record Technology. The 2015 edition electronic health record system must be in place on the first day of the performance period prior to October 3rd, 2019, and needs to be certified by the last day of the performance period. What this means is that your vendor might release an edition of your EHR, but it is not certified yet. So for the promoting interoperability measure, you need to start using a 2015 edition EHR on the first day of whichever performance period you selected, but the vendor must receive certification for that 2015 edition EHR by the last day of that performance period. So, for example, if you choose the last performance period, you must start using 2015 edition EHR on October 3rd, 2019, but it must be certified by December 31st, 2019. Thanks again for joining us today. As mentioned at the outset, we will compile and vet the questions posed today and email you answers. Contact you directly or present responses for the more detailed and research-intense questions at our next office hours call next month. Thanks again for joining us today. We ask that you please take a moment to complete the brief evaluation that will appear when you close out of the webinar. Your feedback is much appreciated and is used to inform our future educational offerings and resource development. Today you will automatically be redirected to an evaluation. We ask that you please take a moment to complete the brief evaluation. Your feedback is very much appreciated. Christine, if you could start the question and answer process, I would appreciate it. Thank you.
Thank you. Ladies and gentlemen, if you have a question, please press star, then 1 on your touch-tone phone. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, press star 1 on your phone now. And we have a question from Kim. Please go ahead.
Hi, this is Kim from Reedsburg Area Medical Center. Our current EHR is not certified for 2015, and we are scheduled to go live February 25th with a certified EHR for 2015. My question is, because we're required to do a full year of quality, how is that going to affect us, or what can we do to make sure that we have the data that we need?
Hi, Kim. So for that quality category, the certification doesn't need to happen until December 31st, 2019. So you don't have to have that done until December 31st, 2019. So it sounds like you'll be all set since that's going to be happening in February.
Okay, so the data that we pull from those first 2 months of our old EHR isn't going to be a problem? Because we'll have 2 months of data from our non-certified 2015 EHR, and then from February 25th through December 31st, that will be, the 2015 certified.
Reader
Elena,
Mona?
this is Mona, and my understanding of that is that you will be attesting that your EHR is certified on the last day of the performance period. It doesn't necessarily have to be certified on the first day. Now,
okay.
Switching EHRs, like if you're going from a non-certified, you're purchasing and going to a brand new new EHR, then the data would end up having to be merged somehow to have the full years. But I don't think that's what you're asking.
No, I'm not worried about merging or getting the data from the two different systems. I just want to make sure that there's not a problem with the data coming from a non-certified source and then, and then going to a certified EHR. So I'm just worried about that 2 months of data that's not in a 2015 certified EHR.
Right, and my understanding is you should be fine as long as it's certified by the last day of the performance period. And I'd also ask, I know, Reed, you had received some information on that directly from CMS, I believe?
Yes, this is Reed at Travis Health. Yeah, basically what you said there, Mona, and also Elena, is accurate. So one of the things, thinking about your particular scenario, the questionnaire here, is that the system itself, from a technical perspective, is probably not changing at all. It's more the certification process that they have to go through as a vendor, and there's a pipeline of many vendors, and there's only a couple certification bodies, accredited test entities that do that certification on behalf of ONC. So the system itself may not be changing. You have the 2015 system in place. It's just the formality of the certification process may not have happened. So where you've documented the underlying data and tables is not changing unless they run into some glitch with the certification process and that body were to say you need to modify your system in some way. Usually not the case. I have not heard of that, but I think you'll be in good standing there.
Okay, because the original, or the EHR that we have now, we're not going to update anything on it to get it to 2015 certification.
Yeah, and that's kind of how CMS structured this is, and why they said, it doesn't actually have to be certified until the end of the performance period or this year, is that they do realize that a lot of vendors have actually done the work, and since we're not in the first year of the program, a lot of that is accurate. Those vendors know, for example, what the changes are in the quality measures and how to code those in their systems, and then it's more the formality of kind of going through that process. And, it's kind of the trust but verify, making sure that the changes that they made are indeed accurate.
Okay, that's all I have. Thank you.
Yeah, you're welcome.
Thank you. And once again, if you have a question, please press star 1 on your phone.
Question in the chat, and it reads, for reporting 90 days under the PI for client portal, am I correct in understanding we only have to have one client utilizing the portal? We are doing a group submission. I don't know, Elaine, if you want to take that or Reed or?
Sure, this is Reed. So basically, sort of yes and no quasi, and I'll explain that. You certainly do have to meet the measure and have at least one in your numerator of somebody that is doing that patient access electronically. In the past, we've typically referred to it as view, download, and transmit through the patient portal. However, because the promoting interoperability category has been restructured, it's more about performance on those measures now. So if you want to do well and earn your 25 points, then you'd want to have, a larger, numerator denominator. Of course, you're going to have many more patients just than one. So it's more about performance and how you'd like to do on that particular objective and measure. But to meet the requirements, you would have to at least one.
And we do have another question over the phone, if it's okay to take it at this time.
Yes.
Okay, we have Randy Terry. Please go ahead.
I'm asking about the security risk assessment. I noticed you guys put a link in there for the HIT or the healthit.gov one. That's a 71 meg file, and we have never been able to download it. is there any tool that we can offer up to the smaller physician offices that we could actually get to?
This is Liz Stratus. We do offer some security risk assessments through Stratus, and I'm not sure, you're in Wisconsin, right?
Michigan.
Michigan. Okay. Does Michigan, do you have any kind of security risk assessments, or, you know, maybe we could forward the information to your team over there? Because there is some helping tools that you don't need to download that huge big file for.
Yeah, that would be really helpful if you want to forward those over to us, and we can forward them out as well.
So if you could forward them to me, and I don't know about others on the call, but we would love to have that.
Okay, I will do some double checking with our powers that be on that risk assessment and see where we are sitting with funding and et cetera, and who can qualify for it, because I know that we had it at a reduced prices. I'm not sure if that's for all states or for just Minnesota, so I'll do some checking before I send it out.
Yeah, I remember back a while ago the state of Michigan did have one. It's probably about 4 or 5 years old. That's why we're reluctant to use it. And it was developed as a result of a federal grant, and it had to be made available to everybody who asked. And sometimes it was reluctantly made available. But so we would really like it if it was, you know, generated from a grant. Especially. So.
Yeah, I don't know the details of our security risk assessment, if it was through the government grant or if it was a private, but I'll do some checking on it. I can't totally promise, but I think there is some resources out there, and I'll have to do a little digging on it.
Thank you much. Appreciate it.
Sure.
Hey, Randy, this is Tisha from Michigan. I just wanted to let you know that I think the one that you're thinking of is through the MCEDA grant that we did for meaningful use.
Yes,
I don't know the last time that was ever updated. I can certainly reach out to Alterum, who was the main grant holder for that, to see if they had an updated version.
Well, that would be great as well.
Yep. Thanks, Randy.
Mm-hmm.
I'm showing no further questions over the phone at this time.
So this is Candy. Excuse me. I was just checking a meeting that we had, just a couple of questions that came up that might be of interest to people. There was a question about how people will do a test that they're not doing information blocking for this year and for next year, and that is going to be through an attestation, just an attestation yes or no question on the portal when it opens up. I just wanted to bring that up.
And Candy, this is Reed at Stratus Health. In addition to that part of that attestation, there's some other things. One of them happens to be the security risk assessment. It's no longer an objective within the promoting interoperability category. You just attest to the fact that you do it, and of course retain documentation for any eventual audit.
And to add to that, Reed, this is Mona, and in January we will be reviewing the PI category, doing a little deeper dive into that, and our office hours will focus around that.
Hey, Reed, this is Candy. Will you just repeat what you said as a follow-up comment, because I'm typing up the notes and I didn't get that.
Oh, no problem. I was just mentioning that within the promoting interoperability category, we've been used to having the security risk assessment as an objective that needs to be accomplished. It was kind of yes, no, but they've kind of broken that out, and it's in that when you go in through the EIDM, as Elena was explaining, when you get to the PI category, there's about 5 or 6 items that you need to attest to, and one of those happens to be accomplishing a security risk assessment. So it's no longer treated as an objective. It's just an attestation, and that's if you don't do that, it's a sort of do not pass go, and you wouldn't be able to accomplish the PI category without doing so, just as you would making that attestation towards data blocking.
Sure, and let's make sure that we're clear about that. That's for the 2019 performance period, right?
That's talking about 2019. Yep. Thank you for asking. So I was getting a little ahead of myself. So we still have 2018 to accomplish and doing the submission and so forth. So, yep, for the current year, it is not split out quite yet. So thank you for asking that, Candy.
Yep, no worries.
There's another question in the chat. It says, I'm curious if you have heard any buzz around adding, including place of service 21, inpatient, and 23, emergency within the PI reporting, because the CMS FAQ doesn't include those places of services. And then the questioner put in a link to the fact sheet for PI for 2019 or 2018. I don't know if anybody has heard anything. I have not heard anything about that. This is Mona.
And this is Lisa. I don't think it's for, I mean, if it's just for PI, place of service, you know, if it's for QPP in general, it's how you're billing the service. But if it has to do with if you can qualify for an exception to that category, that's when they look at the place of service. Or maybe I'm not understanding this question right.
And maybe if the person who asked the question could get it on the call and let us know whether or not we've answered it.
We do have a Melissa Zanzinger queued up. Your line's now open.
Hi there. So I asked a question regarding the place of service. So that FAQ has a lot of information about reweighting if you are a hospital-based provider. Our EHR vendor is suggesting that we add place of service 21 and 23 to our PI reporting only because of that reweighting, but because the FAQs aren't specifically excluding any places of service. So I don't know if you have any guidance on that reporting including all places of service or how that piece works.
So that's the question about is about reweighting then. So you can reweight, yes, if you are more than, is it 75% of your practice is in one of those places of services. So it really only affects those who want to reweight their ACI or PI score.
Right. So we report as a group, and we have, you know, obviously our hospitalists are part of that group because some of their observation encounters may qualify in the denominator. But I guess we're not getting much guidance on why we would include those inpatient places of service, as those providers are probably not going to be reweighted because they are required to submit MIPS based on a group. So when you look them up, they are eligible for MIPS when reporting as a group, so they would, I guess I don't understand why you would ever include place of service 21, specifically 21. 23, our ED providers are not employed, so that one's a little easier.
I agree with you. I think that you probably don't want to put those in because they're not outpatient. Unless you're doing type B services inpatient.
That makes sense. So we can kind of run
B services. Yeah, it depends on what services you're providing. If you're doing Part B services inpatient, let's say an outpatient procedure like a colonoscopy, yes, you should be including those in your denominators.
And we're not. So, okay. Any other? Okay, that's helpful. Just the curiosity around that, or if you had had any other people asking about that.
Yeah, it has to do with how you're billing for the service, not actually really where you're providing it.
Okay.
Anything you're billing to Part B should be included in your data submission. And you need to include at least 60% of the data. So if you do exclude them, I think as long as you're including over 60% of the data, you should be okay.
And we are, and if they ever go out into, some of our hospitalists have gone to nursing homes and such, and so those are all included if it's billed appropriately, of course. But we'll just double check that Part B billing part. Thank you, that was helpful.
We have no further questions over the phone.
There are no further questions in the chat either that I see. This is Mona, and I did in the chat put in a link to the Lake Superior Quinn's quick start guide for the EIDM account. I know that on the resource page there is I think it's about a 54-page document on obtaining an EIDM account, but Lake Superior did put together a quick start guide which is located on our website. So if you do not have an EIDM account and you're just getting started, you might want to start with the short version and see if it answers all your questions before you go through the big, long 54 pages. Elena, maybe we want to remind them one more time how to answer a question or ask a question.
To ask a question over the phone, you can press *1.
Thank you, Mona.
Yeah.
Okay, well, if nobody has any further questions, we can kind of wait and see for a couple more minutes if we get any, but we'll hang out, see what happens. But if you have no further questions, feel free to exit, and we'll be here to answer any questions that you might have. Okay, if there's no further questions, we'll compile and vet the questions posed today and email you answers, contact you directly, or present responses for the more detailed and research-intense questions at our next office hours call next month. Thank you again for joining us. We ask that you please take a moment to complete the brief evaluation that will appear when you close out of the webinar. Your feedback is much appreciated and is used to inform our future educational offerings and resource development. Today, you will automatically be redirected to an evaluation. We ask that you please take a moment to complete the brief evaluation. Your feedback is very much appreciated. This is the end of our WebEx. Thank you.
Thank you, and thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.